Good afternoon and welcome to the GW School of Medicine and Health Sciences 9th Annual Dr. Martin Luther King Jr. Lecture Series. This keynote event is sponsored by the SMHS, Office of Diversity and Inclusion, and the GW Anti-Racism Coalition. I am Dr. Grace Henry, and I have the great pleasure of serving as the Assistant Dean for Diversity and Inclusion. I also want to take time to acknowledge actually our dean who just walked in, Dean Barbara Bass, as well as the rest of the ODI staff, Senior Associate Dean for Diversity and Faculty Affairs, Dr. Yolanda Haywood, who will be facilitating our Q&A portion, as well as our Diversity Program Manager, Delina Booker, and our grad assistant, Tanasua Sambana, who's online, and they envisioned and planned today's event. We are grateful to those of you in the room, as well as those of you on Zoom, that you have chosen to participate in today's event, which falls on the actual birthday of Dr. King, who was born this day in 1929. This year's theme, Advancing the Dream, a time to reflect, imagine, and build a future, draws inspiration from Dr. King's visionary words from the speech he delivered exactly 1 year before he was assassinated. In his speech titled Beyond Vietnam, A Time to Break Silence, Dr. King admonished, "We are now faced with the fact, my friends, that tomorrow is today. We are confronted with the fierce urgency of now. In this unfolding conundrum of life and history, there is such a thing as being too late. Procrastination is still the thief of time." These words challenge us to do more than just recall his dream, but to advance it. Today, we are reminded of the need to engage in meaningful civil discourse, equity, and the ongoing work toward justice in medicine and beyond. And now to today's speaker, Dr. Quinn Capers IV. Dr. Capers is a highly decorated educator, clinician, and advocate for diversity in medicine. He is a graduate of Howard University's College of Arts and Sciences and the Ohio State University College of Medicine. It wasn't even in there, I had to type the D when I got it. Dr. Capers completed his training in internal medicine, cardiovascular diseases, and interventional cardiology at Emory University. Over the years, he has worked in private practice and held faculty positions at Vanderbilt University, Meharry Medical College, the Ohio State University, and the University of Texas Southwestern Medical Center. In January 2024, Dr. Capers joined Howard University as chair of the Department of Medicine. Dr. Capers' clinical expertise focuses on transradial artery approaches for coronary catheterization and stenting procedures, as well as acute coronary syndromes. During his tenure at the Ohio State University, he spearheaded the transformation of the cardiac catheterization lab into a radial-first facility, where the majority of procedures were performed by accessing the circulation from the radial artery in the wrist rather than the femoral artery in the groin. This change led to a sustained reduction in complications in patients treated in the cath lab. Dr. Capers has continued to practice interventional cardiology through the years and has performed more than 4,000 coronary stent procedures, many in heart attack patients. Physician pairs have named him one of America's best doctors 10 years in a row, and his patient satisfaction consistently ranked in the 90th percentile nationally for 6 years in a row. As an educator, Dr. Capers has received numerous awards for teaching and mentoring. In 2019, the OSU College of Medicine's graduating class named him the Professor of the Year, an award reserved for the most impactful educator in their 4 years of medical school. Dr. Capers was also the recipient of the American Heart Association's Clinician Educator Award in 2018, among many other awards for outstanding teaching and mentoring. It recognized thought leader in diversity medicine, racial healthcare disparities, and bias in medical education. Dr. Capers led the OSU College of Medicine to several high marks in racial and gender diversity, while the average MCAT score remained at or above the 90th percentile. From 2009 to 2019, Dr. Capers served as the Associate Dean of Admissions at the Ohio State University College of Medicine, where he directed all efforts to recruit, interview, and select over 2,000 future physicians. In 2012, he led an initiative requiring all admissions committees members to take the implicit association test to uncover unconscious biases related to race, gender, and sexuality. This led to the first study to document the presence and extent of unconscious racial bias in medical school admissions. To date, he has trained thousands of physicians and scientists in strategies to reduce implicit racial bias in patient care and in the selection of medical students, trainees, and faculty. Dr. Capers' research focuses on the impact of racial bias on healthcare and diversifying the physician workforce as a strategy to reduce disparity. His work on confronting and mitigating racial bias in medicine has been widely cited, and he has been an invited speaker at most academic medical centers in the US and several in the UK and Canada. In 2020, Dr. Capers became the inaugural chair of the American College of Cardiology's Diversity and Inclusion Committee, where he led national efforts to diversify the specialty of cardiology. Dr. Capers is an elected member of Alpha Omega Alpha Medical Honor Society and the Association of University Cardiologists, an elected honorific society of the country's leading academic cardiologists. Now, without further ado, please join me in welcoming today's MLK keynote speaker, Dr. Quinn Capers IV.
Thank you so much. What a wonderful introduction. I'm really very happy to be here. So we're neighbors now. I've been here for a year. So hello, GW. We are happy to be right around the corner from you. And you didn't hear this, but I went to undergraduate at Howard University. And so this is, in many ways, a homecoming for me. And I'm very happy to be here. In fact, when I walk through the cafeteria, my mind goes racing back to a time when I was a pre-med student, eating in the hospital cafeteria. Because although there were many places to eat on campus as an undergraduate, I preferred eating in the hospital cafeteria, so I could see those doctors walking back and forth with their white coats on to inspire me. So when I'm going to the cafeteria now, if I leave my white coat, I'll say, oh, let me go get that thing, because there might be a pre-med student in there looking at me. So thank you very much for this invitation. And on such an occasion that is so critically important for us, and I've kind of subtitled my talk, Diversity in Medicine and the Fierce Urgency of Now. Yesterday is too late for us to do everything we can to diversify medicine. Our physician forces, our healthcare provider forces need to come a little bit close. Right now we don't come close to mirroring the wonderful diversity in this nation. And if that is what you advocate, if that's what you're for, then right now you're kind of on the hot seat. Right, we now are in this era of anti-diversity, equity, and inclusion. This is a time for courage, and you should be proud of a lot of the things that you've done here at GW. So, where's my? Here we go. So I want to take you back to a time that initially is difficult to think of, especially when we see this picture of George Floyd. Remind you that as a country, we watched this murder of George Floyd often on repeat. We saw it more than once. And how it actually spearheaded a coming together that we hadn't had in a couple of decades here in this country. I call that our racial reckoning. For a couple of years there, here's what happened. I say that George Floyd's death was the death that launched 1,000 diversity committees. Because as you know, after that, and I'm not saying this in a derogatory manner, I'm saying that people really wanted to do something about it. What can we do? Let's start a diversity committee. Let's start a health equity committee. Let's start an anti-racist committee. And there was really a flourishing of such committees. And there was an explosion of diversity-related jobs, positions, and titles. I'm sure that many in this auditorium, your inbox, your email inbox was full right after the George Floyd murder of job. You know, come and be the diversity dean of this or the chief health equity officer of that. And again, it was an attempt of organizations to say we have to do something about this. Colleges, academic medical centers, I'm sure your own institution, came out with some bold motto or anti-racism statement, something saying that racism doesn't live here. This is all very, very positive stuff because it was a sincere effort of many individuals and organizations to understand and attempt to mitigate racism and to enhance diversity. So those were some good times, 2 years. And then, yes, you know what happened then. Then there was a pendulum swing. There was a segment of society, without going into too much detail, you know this, there was a segment of society that didn't like that. They didn't like all that focus on anti-racism and diversity, and their fists were clenched, and they were grinding their teeth, and they were waiting, and started to fuel this pendulum swing, which has had some important moments, starting with the Supreme Court's ruling that you should no longer consider race when making higher education admissions decisions. As of 2022, 30 of the 50 states in our nation have at least considered in their state legislature anti-DEI bills. School boards have been pressured into book bans. This is almost a scary look at yesteryear. And I was in Texas for 3 years at UT Southwestern, as you've heard. Just before I made the transition to come up here to DC, I remember reading about a small school district in the state of Texas where several educators were lobbying the school board to remove in the lessons and any books that refer to slavery, to remove slavery and replace it with a different term, involuntary relocation. We're not going to talk about slavery. That could make people feel bad. So let's call it something else. Let's call it involuntary relocation. Fortunately, the school board voted that down. But as you know, people are persistent. So I'm sure they're regrouping and they'll plan to come back. This is the era that you and I now live in, the anti-diversity era. So Texas was number 2. It was the number 2 state to pass this anti-DEI legislation. This is the law now in the state of Texas. And it has been in force for exactly 1 year. Went into force January 2024. You shall not, your institution shall not maintain a DEI office. So every medical school in Texas had to close their diversity, equity, and inclusion office. Many of those workers were out of a job. Some were relocated to different jobs. You can't hire somebody else to do that work. And this is interesting. So you can't ask of an applicant for a job or a student what they plan to do about diversity. So imagine you're a university and you're looking for a new dean of student affairs. This question, let me frame this question for you. This question, gee, can you tell us what you did at your previous university to enhance inclusion, and what do you plan to do here to enhance diversity and inclusion? That question is illegal. You know those list of questions that we have that are against the law, one of them asking a woman, what are your family plans? Do you plan to have kids? So you can add that question. What do you plan to do to encourage diversity, to the list of questions that are illegal? And there are some others. I'll talk about some of the others as we go forward here, but this is a time of courage, and the urgency is fierce, and the urgency is now. And it's not just the states. So you all may be familiar that a US Congressman, Murphy, who is a physician, has tried to get traction on a national anti-DEI bill. And this one isn't just about any public institution. This one is coming directly for us. This is medical schools. This is an anti-DEI in medical school bill that, if it became a law, would ban diversity offices in all medical schools. Compelling students to say that America is racist, which we all do every day, right? We walk into a room and say, repeat after me, America is racist. But this bill says that you can't do that anymore, which while that's chuckle-worthy because nobody is doing that, nobody has been doing that. But the interesting thing is that there is a halo effect of bills and laws like this. And often we don't read the detail of what's in the bill. We just say, just shut it all down. And those who are introducing these bills, I think, are aware of that. So the fierce urgency of now, Let me make some statements here and we'll talk about them. Racial healthcare disparities persist, and they are strong. The Institute of Medicine, which is now called the National Academy of Medicine, first published this landmark study about racial healthcare disparities all the way back in the early 2000s. So it's been a couple of decades. As I'll show you, things have not changed very much. So we know that it's a problem, and those problems persist. We, as academic health centers, we should be leading the charge in research and education and clinical care and in policy that helps to reduce those disparities. Physicians and other healthcare providers, our nurses, our pharmacists, our dentists, our respiratory therapists, our physician's assistants, we need to be activists. It's no longer enough. If you truly care about health equity and reducing healthcare disparities, it's not enough for me as an interventional cardiologist to be very skilled at how I implant that stent and that stenosis in the coronary artery. I've got to do something else. It's a time for all of us to be activists, and in this era, this will take courage. So if you don't mind, I'm going to get cardiology-centric for just a bit as I give you some demonstrations of current healthcare disparities. But I'm talking about cardiology. It could be cancer, it could be diabetes, it could be pulmonary disease, it could be obstetrics and gynecology, it could be psychiatry, it could be any field of medicine. But I want to give you just a few examples because I think some of them are very striking. So it's a good time to be a cardiologist. We got some wonderful tools to treat our patients and improve the quality of their lives. We have automatic implantable cardioverter defibrillators. We call it, it's like having an emergency room in your chest. We have this device in your chest that monitors your heart rhythm. If your heart stops, bam, shocks your heart, keeps your heart going again. It is absolutely life-saving. Number two, treating heart attacks. We know now the best way to treat a heart attack is to open that coronary artery as fast as possible. That starts with a coronary angiogram. That's the test where we take a tube, put it in the wrist or the groin, advance it to the heart, and inject X-ray dye to show us the arteries. Coronary angiogram. You can't treat a heart attack without a coronary angiogram. So keep that in mind. And number three, we have wonderful ways to restore blood flow to our patients with critical lower extremity ischemia or poor circulation to the legs. Let's look at how this wonderful technology is being applied. Let's start with AICDs. This study in 2003 looked at Medicare patients who survived a cardiac arrest. So their hearts had stopped. As you and I know, if your heart stops, you are most likely not going to survive, but a few people survive. We have guidelines. Cardiologists have guidelines by the American Heart Association and the American College of Cardiology that tell us how to deploy our technology. And so we have a list of people who should get a defibrillator. Number one on the list is if you were lucky enough to survive a cardiac arrest, if it happened to you once, it might happen again. So you should get a defibrillator. The study showed in this random assortment of 6,000 Medicare patients that the odds ratio for those Black cardiac arrest survivors compared to those white cardiac arrest survivors to receive a defibrillator was 0.5. Said differently, for the same diagnosis, the Blacks were only half as likely to receive this life-saving therapy. Now, I might say, Quinn, come on, man, that was about 2 decades ago. Got anything more recent? Yeah. This one here in 2016 was a national survey where they looked at the inpatient charts of patients admitted to the hospital with severely weakened heart muscle. If your left ventricular ejection fraction is less than 35% and you still have congestive heart failure symptoms, then you're at risk for cardiac arrest. One of the things that a weak heart will do is sometimes it'll just say that I quit. It'll just stop beating. So they are number 2 on our list from the ACC and AHA of who should receive a defibrillator. In this study, what they found in reviewing patients' charts, 21,000 of those patients who had criteria, Blacks and Hispanics were less likely to even have it mentioned in their chart or to have anybody in that hospitalization say anything about an AICD. And this is not 2 decades ago. 2016 was not that long ago. Now, this is national data. Sometimes when I talk about national data, people in the audience will get nervous and they'll say, well, it's not like that here. Well, maybe it isn't. Maybe it's not like that at GW. This is the United States of America I'm talking about. Let's talk about critical lower extremity ischemia. So there are racial disparities in the deployment of AICDs. How about in critical lower extremity ischemia? This is a study published last year where they looked at over 80,000 patients in this country who presented with critical lower extremity ischemia. That is the blue, cold, pulseless foot. Something must be done. And there are a range of things that can be done. One of the things that are done to people in such a situation is a limb amputation. So they specifically wanted to see, are there racial differences in those who are treated with an amputation versus those who are treated with revascularization, restoring blood flow. What they found when they compared Black and Hispanic patients to white patients, the odds ratio was higher that Blacks and Hispanics would receive an amputation. Blacks were 30% more likely, Hispanics a whopping 59% more likely than whites to receive an amputation. And when you look at this data, you have to be thinking, and I'm sure you are, well, wait a minute. Now, what we know about patients from underrepresented and underserved backgrounds is they usually wait a long time in the course of their disease. So you have to adjust this for severity and extent of disease at presentation, because if it's true that patients from underserved backgrounds wait until there are no open blood vessels from the thigh to the toe, then there's nothing for a surgeon to bypass into, and there's nothing for an interventionalist to stent. So you've got to adjust for that. So these authors did, and here's what I want you to take a look at, these hazard ratios. This is unadjusted data, and look what happens when you adjust the data for the extent of disease at presentation and the severity of disease at presentation. Look at these numbers. You ready? So almost nothing, right? Almost nothing. So that argument that people will often use, well, wait a minute, maybe the disease burden was different. No. Even when you adjust for that, this disparity stays very difficult to look at. Let me go on now to coronary angiograms. Remember that test that shows you if the coronary arteries are blocked or not? This is a study published just last year by Ashraf and colleagues that looked at patients by race receiving a coronary angiogram if they present with a heart attack, a non-ST segment elevation myocardial infarction. This is not GW, it's not Howard, it's not necessarily Washington, D.C. This is aggregate data for the United States of America. This first one looks at the rate of receiving a coronary angiogram. And remember, you can't treat a heart attack properly unless you know what the coronary arteries look like. Whites versus Blacks. Whites are the circles here. You can see at every time point studied, there was a significant difference. Whites with heart attack were more likely than Blacks with heart attacks to receive a coronary angiogram. This next one looks at whites versus Asians. And here, they're talking both South Asians and East Asians. And you see, at every time point, whites were more likely to be treated with a coronary angiogram when they have a heart attack. This next one looks at Hispanics, whites versus Hispanics. In the first two time points, they were almost equal, and then you got this split. So if I sum up this slide, what this shows in America is that if you present to a hospital with a heart attack, if you are Black, Hispanic, South Asian, East Asian, you are less likely to get the appropriate test than if you are white. I hope I've convinced you that there's a problem. There is a problem, and what I want to say to you is that it's not new. The first studies to show things like this were way back in the early 90s, and they continue today. So that's over 4 decades of studies in the literature documenting these disparities. So this is not news to those who are looking for this kind of data. This isn't a big surprise. We've been writing about it for decades. We published this review paper a few years ago, and what we found is that in a 20-year period, there were no fewer than 300 papers in the literature documenting the racial disparities I just talked to you about. 300 papers. And the sobering thing was that things were just as bad at the end of that 20-year period and documenting the problem 300 times as they were at the beginning of that period. So documenting the problem, it's important, but that's not enough to actually change it. It takes activism, it takes you and me getting into some good trouble. So why is diversity in medicine important? That could be a whole separate talk. But I want to just ask you to think about this for a moment in your particular field of expertise. I want you to imagine that you are in, the doctor's lounge or the cafeteria, Or maybe you're in the coffee shop where Dean Haywood just took me. And a colleague comes up to you and they ask you about something in your field. Why do we use drug A instead of drug B? I'm going to bet you could run down the studies and literature telling them why you do that. But what if they jammed you up and said, why do we really need diversity in medicine? And don't tell me about your feelings. What's the data that shows that diversity in medicine is something we should strive for? My question to you, and maybe an assignment for you, is if you can't rattle off the studies, then that's your assignment tonight. Would you be caught flat-footed? Would you be like a deer in the headlights? Or would you be able to stand there and go toe-to-toe and talk about the data that shows that more diversity in medicine will save lives? We don't have time to talk about that today, but I've put it in the form of a multiple choice question. Is it because underrepresented minority physicians are more likely to serve the underserved? That's one choice. Is it because minority patients are more likely to follow the recommendations of minority physicians? Is it because diversity on research teams enhances the impact of the research? Is it because a diverse physician workforce has been shown to and will continue to reduce racial healthcare disparities? There is data to suggest that each one of these is true, so the real answer to this question is all of the above. So please arm yourself with the data so that when that colleague comes up to you in the doctor's lounge or in the coffee shop, that you can have a pleasant debate with them and show them why diversity is important. I want you to get into some good trouble. That means advocating against what is negative and for what's positive, even if it means you'll face some adverse consequences. Be an activist for diversity in medicine and against racial bias in medicine. And do it, be an activist in the 3 pillars of academic medicine: clinical care, research, and medical education. Let me show you what that looks like. How about clinical care first? What does that look like? What does it look like to be an activist in your clinical care? Well, where you choose to train and where you choose to practice is an act of activism. Choosing to serve the underserved, choosing to serve those under economic distress, choosing to serve those who societal structures of inequity, societal racism puts them at a disadvantage. Choosing to serve that population is an act of activism in your clinical care. Many of our academic medical centers do just that. They tend to be located in places where we serve a lot of underserved. And then how do you utilize your skills after hours? This is data from the AAMC. Just wanted to make a point with this. Those of you who work in student affairs know, and those of you medical students, we got some medical students here, don't we? Some medical students in the audience. So medical students, you might not remember this because there's a lot going on orientation week when you first get to medical school, but sometime in your first week, you sat down and you took a survey by the AAMC. And let me tell you that you're going to sit down sometime graduation week and take a survey again. And there are people collecting data, and they compare your answers from when you were just coming in to when you were graduating. And this analysis and brief from the AAMC is looking at that with respect to one particular question, intention to serve the underserved. Yeah, there we go. So they looked at in this analysis, 80,000 medical students were asked this question: do you plan to locate your practice in an underserved area? And they wanted to look at the answers upon entry and upon graduation from medical school. They found that Black and Hispanic students were more likely to answer that question, yes. White and Asian students were more likely to answer that question, no. Now, they were interested in the range of answers because the answers, possible answers are yes, no, and maybe. So they specifically in this analysis wanted to look at everybody who answered maybe their first week of medical school and see how that answer changed 4 years later when they were about to graduate. What they found is that Black and Hispanic students that were initially undecided were more likely to answer yes by graduation. White and Asian students that were initially undecided were more likely to answer no by graduation. So this is a note for our curricular people in the audience. What are we doing in medical school that is turning people off of the idea of serving the underserved? I really wanted to make the point, though, that our students of color come into medical school with this legacy in their heart and in their soul to serve the underserved. And it's not just talk. This slide, I wanted to put every study that has ever shown that physicians who are Black, Hispanic, or American Indian are more likely to locate their practices in communities where they serve the underserved. I wanted to put all those studies on one slide, but the slide wasn't big enough. So you'll have to settle for 10 studies, all showing the same thing. The jury is in. It's no longer a question. Physicians from underrepresented backgrounds tend to go and serve underrepresented communities. So it is an act of activism where you choose to train, where you choose to practice, and what you do after hours. And a shout out here to our medical students running a free clinic. I know your medical students have the same thing, medical students do. That is an act of activism, reaching out and helping those who are underserved. What about medical education? What does that look like? What does it look like to be an activist in medical education? Well, you got to teach just what we're talking about. Teach about disparities and inequities and solutions, and do that teaching even when the topic is uncomfortable. And that's that getting into good trouble that we're talking about. So I'm on Twitter. I know social media can be used for good or for evil purposes, but there's some good to it. One thing I like about Twitter is you can create a poll. And so occasionally I will poll my followers. And here's a poll that I did not too long ago. It says, fact one, asthma is the inflammation and constriction of airways due to pathogens and allergen. Fact two, housing segregation resulted in US Blacks being clustered in neighborhoods with poor air quality, and as a result, Black children have a higher asthma mortality than whites. Which of these should be taught in medical school? And the reason I'm asking this is because we have some strong advocates, even former medical school deans, saying you should just be teaching fact one. Fact two, that's not the place of medical school. We're not sociologists. We're not social workers. We're not politicians. We're not city council persons. Medical school curricula is no place to teach fact two. So I polled the group, and I'll show you in a minute what they said. Here's another question I asked. The Tuskegee experiment was a US study in which Black men with syphilis were intentionally deceived into thinking they were being treated so that researchers could study the ravages of untreated syphilis. Should this be taught in medical school? There are a lot of people who say no. That's, you need to be worried about biochemical pathways and the anatomy of the shoulder. My shoulder's kind of sore right now, and that's why I said the anatomy of the shoulder. That's what you need to be teaching in medical school, not this. There are some very powerful people who feel that way. Well, I'll show you what the people said. So actually, I said fact one or fact two or both. 93% said that you should teach both of these facts. Now, this is a specially curated population. These are my followers on Twitter, so there might be some bias there. And 96% said all doctors should know about the Tuskegee experiment, but there were 4% who weren't sure, and 733 votes. So that's about 30 people who looked at this and said, no, we should not be teaching that. Be an activist. Be an activist and get into good trouble as a medical educator. One of the most enjoyable times I've had in my professional career was at the Ohio State University. Thank you for the shout out on the when I coupled with a PhD historian to teach a class in healthcare disparities to undergraduate college students. And he was a PhD in history, and his specialty as an historian was the medical care that slaves received on the slave plantation. So he talked about healthcare disparities from that perspective, and I talked about modern healthcare disparities. But we learned a lot. I want you to remember this term. One thing we talked about was a disease that the physicians who worked on the slave plantation, and they were hired by the slave owner, they invented a disease called drapetomania. Drapetomania, D-R-A-P-E-T-O-M-A-N-I-A. Drapetomania is a disease, according to these doctors, that describes this mental illness that slaves had that led to them continually running away. So if a slave ran away and was captured, dragged back, and beaten to within an inch of their lives. And then as soon as they healed, they ran away again. To these doctors, that had to be some form of mental illness. They suffered from drapetomania. You know the cure for drapetomania? Is chopping off a body part so they can't run anymore. So we were going deep. This is what we were doing in that class. I've also made it almost a part of my contract. My former chair at The Ohio State University will tell you that when he offered me a job, I was in private practice in Columbus, Ohio. I said, okay, there are a few things I want to talk about. And he said, oh no, to himself, like he's going to ask for some more money, because that's what everybody does when you're about to hire them. And he says he was pleasantly surprised that I said, I want to put in my contract that I get to teach to medical students. And this is one of the reasons that I wanted to teach to medical students. You're looking at the curriculum for first-year medical students, and in the same week in which we're learning about EKGs and learning about peripheral arterial disease, we're learning about black and white disparities. So we did that for 10 years while I was there. When I went down to UT Southwestern, same deal. We're going to teach about healthcare disparities to the first-year medical students. Now that I'm at Howard, this is a week. Same week, we're learning about pathology of cardiomyopathies and arrhythmias. We're learning about racial disparities in cardiovascular care. No physician, no nurse, no respiratory therapist, no pharmacist, no dentist should graduate without learning about racial healthcare disparities and some things that we can do to fight those disparities. What about GME trainees? This is an opinion piece written because the issue of having racial healthcare disparities, social determinants of health, part of a cardiology core curriculum had been a subject of debate. And in this, we said, despite the fact that there are more than 30,000 adult cardiologists in the US armed with tools to strengthen failing hearts, open clogged arteries, and stabilize deadly arrhythmias, Blacks, Hispanics, and other minorities experience a disproportionate burden of cardiovascular disease and are often undertreated. We need to teach this to our cardiology trainees. If all I do is teach you how to expertly read an EKG, how to perform a heart catheterization, how to interpret and perform a cardiac ultrasound, and then you graduate and go join all the other cardiologists out there, it is likely that you might go out there and contribute to these healthcare disparities. So we're going to make sure, while you know how to read an EKG, you know about racial healthcare disparities and what underlies those disparities, and most importantly, what you can do about those disparities. Be an activist as a medical educator and get into some good trouble. So this is me with fellows at UT Southwestern and now with our fellows at Howard. Right after that lecture, they said, they called me the selfie king. I said, let's take a selfie and show people what we're doing. The third pillar is research. What does that look like? What does it look like to be an activist in your research? Well, do research that points out the problem. We've already talked about that. That's important. Can't stop there. We've got to talk about solutions too. But pursue that truth even when it makes others uncomfortable, and that's that good trouble we're talking about. John Lewis said it best, and John Lewis, of course, one of Dr. Martin Luther King Jr.'s most able lieutenants. So we did this study where we looked at redlining. If you're not familiar with what redlining means, it's a term that came from the fact that this was legally done in the United States. In the housing market, when people were looking for a home, there was a map of the city, and the realtors and the lenders of mortgages, they would take that map and they would draw with a red line around the undesirable parts of the city, where most of the smokestacks were, where most of the pollution was, where most of the high crime was, where the schools were underfunded. And those were the only places that they would give mortgages to for Black people. Or sometimes redlining is used the other way. They drew a line around the desirable parts of the city, and they would not allow mortgages to Blacks. Now, I want to walk you through something. Let's say your grandfather, your great-grandfather came up from the South many years ago with some money in his pocket, and he wanted the same thing that we all want, a home in a neighborhood that's safe, where his kids and grandkids can grow and thrive. And he goes to get a mortgage, and he doesn't know anything about redlining. All he knows is, they tell me I can have this house. So he buys that house. living in that house, growing up in that house, generation after generation, our research says put you at risk for congestive heart failure. Now, your grandfather didn't know that. I'm betting that most of you, many of you in this room, that house is probably still in your family, isn't it? That's grandma's house. Maybe you played at that house. Maybe that's your auntie's house. This is legal segregation that is leading to the death of Black and brown people. And this is what we have to be activists against with the fierce urgency of right now. And this is the kind of research that can get you into some good trouble. We also did a survey study of cardiology fellowship program directors. So we wanted to know how they feel about diversity or the lack of diversity. Cardiology is one of the least diverse of all of the medical specialties. So we surveyed them and we asked a couple of questions. Here's one of them. One is this: diversity is a driver of excellence in healthcare delivery. In other words, the more diversity amongst your providers, the better the care delivered. Do you believe this? Fortunately, almost 70% said yes. 5% said no, I don't believe that. 25% maybe. So that's 30%, 3 out of 10 of respondents to our survey who are program directors. Now, you don't get to be a cardiologist until you get past the gate of that cardiology fellowship selection committee and their program directors. So 3 out of 10 of them are unsure that diversity enhances quality. We also did something else. We gave them 10 characteristics of applicants to cardiology training programs. We said rank them. Rank them according to what are most important when you're making your rank list. Here's what we found out. The most voted upon characteristic was clinical skills. I got no problem with that. Do you have a problem with cardiology program directors saying the most important thing for us is clinical skills? I don't have a problem with that. Number 2, though, was ability to fit in. I wonder if that means the same thing to you as it does to me. Ability to fit in. So let me think about that. One way I can think about that is if I am leading a cardiology program that has almost always had mostly white males, and now a young lady of Middle Eastern descent who wears the hijab is applying, will she fit in? Is she going to be a good fit? If number 2 on our list is ability to fit in for our jobs, for our residency, for our medical school, for our faculty, if we are only wanting to take people that fit in, we're never going to move this needle in terms of diversity and inclusion. And you can see where of those 10 characteristics, one we gave was diversity or the ability to enhance the cultural competency of the fellowship program, and that came in dead last. My fellow, at the time I was an interventional cardiology fellowship program director, my fellow program directors were not happy with us. They said the questions were asked in a way that put them in a bad light. I said, sorry, that's that good trouble that you need to be in. You need to be courageous. When I was the dean of admissions for 10 years at Ohio State, we had every one of our large admissions committees, a very large committee, 140 people. That's a pretty large admissions committee, isn't it? I mean, the class size was 200, so we almost had as many people on the committee as in the class. We had every one of them take several of these online, free, available to the public, implicit association tests, which looks to uncover what are some of your hidden biases. What we found is that all groups on the committee, we had men on the committee, women, medical students, and faculty, all groups had moderate to strong levels of what's called implicit white race preference. What does that mean? Implicit white race preference means that when I look at a white person's face, my mind unconsciously associates that face with good things, family, joy, love, etc. And when I look at a Black person's face, my unconscious mind automatically associates that Black person's face with negative things like crime, violence, pain, fear, misery, danger, etc. The men, the women, the students, and the faculty on the admissions committee all had high levels of implicit white race preference. That's the negative side of the study. The admissions committee wasn't too happy with me for publishing this. but you have to be an activist and you have to pursue the truth wherever it takes you. But the good part of the study was this. We then went immediately into an implicit bias mitigation workshop where we talk about some very simple tools that you and I can use to help us override our unconscious biases in the moment when you're interacting with somebody. The result, the next class was the most diverse class we'd ever admitted at The Ohio State University College of Medicine. So we made unconscious bias mitigation training an annual requirement for anyone on the admissions committee. Scholarship in DEI, a case study. So this is still in research. And I want to ask, before I get into the details here, how many of you have heard of what now is the infamous Wang paper? Raise your hands. Okay, so not very many. Well, Norman Wang was a cardiologist, and he wrote this paper, and looking at the title, you can think it's an argument for diversity, but actually it was the opposite. It was an argument against diversity in cardiology. And in this this single author paper, he made several remarks. One contention he had was that, yes, it might be true that we don't have very many Black, Hispanic, and American Indian cardiologists, but it's because they're not qualified. This was written in the paper that was published by who? The Journal of the American Heart Association. Another contention he had in this paper was this. It might be true that Black and Hispanic and American Indian cardiologists are more likely than other cardiologists to serve the underserved, but that's because they didn't pass their board exam. And you and I know that if you don't pass your board exams, well, you can't practice in, the best of the best hospitals. You have to go out some rural area or some underserved inner city area. So this single author paper, a perspective piece, was published by the Journal of the American Heart Association. I want to dive into some details here. These are Wang's words here. So to support his contention that the reason that minority doctors are so likely to serve the underserved is because they struggle to pass their board exams, he made this contention where he's citing a study. He's saying this hypothesis was supported by a 1995 California study, please listen carefully, that demonstrated primary care physicians who were not board certified were 1.6 times more likely to serve underserved areas compared to their board certified counterparts. That is what he says the study said. Let's go to the study, to what the study actually said. It said non-board certified family and general physicians were 1.6 times more likely than other non-board certified primary care physicians to serve the underserved. The paper was touting the benefit of family medicine as a specialty. It was saying that family physicians, as opposed to pediatricians, as opposed to general internists, are more likely to serve the underserved. But what he said was quite different. And my question to you is, was that a mistake? Could be. I mean, you write papers, I write papers, we make mistakes, that's what editors are for. Was this a mistake or was this willful? Let's go on to another one. To support his contention that Blacks and Hispanics are not qualified to be cardiologists, and that's why they're in such short supply, he quoted a study that was from a university that had made good progress in turning their cardiology program into one of the most diverse in the nation, and they wrote a how-to for others to do it. So we quoted them as saying, we made it a priority to rank underrepresented medicine applicants more aggressively. We accepted less competitive applicants in an effort to increase diversity. That's what he said, the authors said. Let's see what the authors really said. So they said this, but the very next sentence was, however, USMLE score comparison shows no significant difference between URM and non-URM fellows matched to the program. It was the very next sentence. His leaving that out, my question to you is, was that a mistake? Or was that intentional? Now, he made a lot of mistakes with this paper. One of his biggest mistakes was, this was my paper. When this was brought to my attention, I was like, oh, really, dog? Do you know who I am? You're using my words to make an argument against diversity? And I got to tell you, y'all, I felt some kind of way about that. I mean, I took that personally. So So we gathered a group of authors, some at his home institution, University of Pittsburgh, and we found all of these. I've just showed you two, but there are 6 or 7 of misrepresentations in that perspective piece. And we wrote to the editors, and the editors retracted the article. They said that, we're sorry, this got biased. We've got a review process. Somehow this sneaked through the matrix. And so we apologize, but we no longer stand behind this. Now, I'm inclined to believe them when they say that, the Journal of the American Heart Association. But I'm also concerned that maybe it wasn't that the editors and the reviewers missed some things. Maybe it's that they agreed and they said, it's about time somebody said it, and it was published. But to their credit, the Journal of the American Heart Association did several things. They had a series of meetings, and their response was to consider appointing an associate editor for DEI. That's a great thing for a journal to do. They decided not to do that, but they did put together a subcommittee that screens submissions that have anything to do with racial disparities or inequities, and they have policies in place for people who submit this work. So now if you submit an article to JAHA, for instance, on the outcomes of Hispanic women after heart transplantation, the first thing is you'll be immediately asked, why are you looking into this? Why are you talking about race? And they'll look at your paper and say, I don't see anything in your paper that talks about the societal racism that Hispanics face. You need to put that in your paper before we'll consider this. There also was a shakeup of the staff, and there's a new editor-in-chief. Want to see him? Dr. Bruce Obiageli. So this is a good response for a journal, and we want other journals to at least look at some of these policies. This is what being an activist as a researcher looks like, and being one who is getting into some good trouble. So put it all together. Now go get into some good trouble. Just a few examples. I just finished my 4-year term as the chair of the Diversity and Inclusion Committee of the American College of Cardiology. One of our projects of which I'm most proud is our internal medicine mentoring programs, where we mentor cohorts of internal medicine residents who come from the groups the most underrepresented in cardiology. Our goal is for them to be very competitive fellowship applicants. And we start off each of those cohorts with a Zoom meeting. This is a meeting with our African-American residents, with our residents who identify as LGBTQ+, with our Indigenous and American Indian residents, with our Hispanic residents. Looking at our data, now our preliminary data shows that 4 years of doing this, that over 80% of these people have been successfully matched in the cardiology fellowship program. So the face of cardiology, we hope, will be changing. Now, all we do is mentor them to be competitive fellowship applicants. That's all we're doing. The Selfie King strikes again. This is at ACC 2024. Not only do we mentor them and have a series of webinars for them, but we actually pay for all of them to come to ACC every year. And standing behind me here are 400 Black, Hispanic, women, and LGBTQ+ internal medicine residents who aspire to be cardiologists. So this is getting into some good trouble. When I was the fellowship program director of interventional cardiology at Ohio State, we knew that we wanted to do something about those healthcare disparities in interventional cardiology that I've shown you. So we made it a part of our application process. So we actually ranked our many applicants on 5 characteristics: clinical skills, collegiality, academic curiosity, leadership potential, and the likelihood that they will go out and be a champion of health equity in the field of interventional cardiology. Each of those were weighted equally. So if you did very well on the first 4, but you got a 0 on number 5, you weren't getting in to Ohio State University's Interventional Cardiology Fellowship Program. How do you do that? What does that look like? Well, you just ask them the questions. Have they participated in community outreach since medical school? Have they been immersed in a group of people other than their own? Have they worked at a hospital where they serve disadvantaged? Have they done a scholarly project on health equity? You get points for that. You can easily see that in ERAS. And I want to point out, look at these. You don't see anywhere in there race or ethnicity. So you can self-identify as white, have the whitest skin, the blondest hair, and the bluest eyes, and be somebody who has done a scholarly project on health inequities. Be somebody who's been at a hospital where they serve the underserved. But this is one strategy that is not illegal. And we encourage you to look at your selection processes and what you are valuing in that selection process. We've also done these implicit bias mitigation workshops across the country. This is an example of one now that the law now prohibits. I was told at the University of Texas Southwestern, you can't do that anymore. So we took the show on the road, and we do it at national conferences and at other medical schools. Bias and equity teaching rounds, where we actually hijack our internal medicine grand rounds and talk about instances of racial bias that might have affected patient care. And then we talked about ways to make sure those don't happen again. I'm going to skip through these and just say that now is the time for courage, whether you're taking a knee to protest police brutality, marching so that racism can be made a public health issue, or like these students in the lobby of Parkland Hospital at UT Southwestern, you know what they're doing? They're registering voters. Now's the time for activism and activists. Now's the time to get into some good trouble. We are with you. We've got your back. We're proud of you, your neighbors. We are very grateful that you invited us here. Racial healthcare disparities persist. We should be the leaders. We need you to get into good trouble. And in this anti-DEI, anti-woke era, that takes courage. But who's got more courage than Dr. Martin Luther King Jr., who said, of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. Thank you very much for your attention. I'll be happy to take any questions.
Thank you, Dr. Capers, for admonishing us that we need to be getting into some good trouble. I like being a troublemaker, so
Yes, I know you
getting
do.
into good trouble is good for us. I wonder, I want to say more about your talk, but I'm going to ask the audience if anyone has any questions. Oh, you got the mic. Go ahead.
Yeah. Okay. So thank you so much, Dr. Capers, for your evidence-informed talk this afternoon. My name is Miranda Ward, and I teach in the undergraduate health sciences program. And so hopefully you'll do a selfie with this group before you leave. But the other thing I wanted to share is that I really appreciate you underscoring the importance of the sentiment around that it is racism, not race, that actually, contributes to racialized health disparities. And I think that's really important. One of the things that we also believe in and try to really facilitate that discussion amongst faculty. So we actually have some curriculum guidance where we encourage faculty in the School of Medicine and Health Sciences, when talking about race in clinical cases, to not include it in the medical history, because, we're trying to move away from race-based medicine and, there's no biological basis to race, to putting it into the social history, to the point that you and some of the colleagues that you mentioned and the work that you've published is the impact of racism. So thank you for that. But my question is, what are your thoughts on how we can change the narrative around DEI hires? I feel like when you were talking about Norman Wang, I feel like it's that kind of storyline, right? Oh, they're not qualified if we don't do the DEI hires, like they otherwise wouldn't get it on their own merit. So what are your thoughts, or have you had any experience on pushing back against that narrative around DEI hires? Or are you even in support of DEI hires? And what are your thoughts on that?
Well, I'm definitely in support of diversity, equity, and inclusion, and that means hiring and a bunch of other things. The best way to fight back is with data, and that and don't feel in any ways discouraged about that, because I could see that could sound discouraging if you said, oh man, now he's saying we got to do a 5-year research. No, the data's already there. So that's the best way to fight back. We are proud in academic medicine to say we follow evidence-based medicine. I'm not going to switch from using this blood thinner to using that blood thinner until you show me the data that this one is better. But there's data that patients do better when we have more diverse providers. And so the best way to fight back is with journal clubs, with grand rounds, with curriculum, especially for those that are still a captive audience, our health profession students, our residents, and our fellows. So using data is I think, going to be the best way to fight back, and creating more data. We need to create some more, but there's plenty that's already there.
I have a question back here, and then we have Dean.
All right. Thank you so much, Dr. Capers, for the informative talk. I'm
You're welcome.
Siobhan Onuma, internal medicine.
Are you one of our students?
I,
Oh.
I'm not, but I have spent some time at Howard. I'm actually the internal medicine residency training program director, so I'm quite flattered that I look like a student. But and so recently having published a chapter on like physician trends in internal medicine in particular in DEI, and thinking about the work that you're doing and how we know each level from medical school enrollees to residents, internal medicine residents as we're talking about now, and then to your point, cardiology fellowship applicants, but the applicants are there, but the ones that are actually matched continue to dwindle. I wanted to know, there was that recent article that was published since the SCOTUS decision showing that that the medical school enrollees are having declined despite having a number, increase in the number of Black, Hispanic, and Native actual applicants. And how do we counteract that? Because now we're going to continue to have a dwindling pool, and the pathway is just continually to wither. And how can we really work towards health equity without the true diverse healthcare workforce?
Thank you very much for that comment. I don't think we can have true health equity with a healthcare workforce, physicians and other healthcare providers that is so non-diverse, and it doesn't reflect what we have. So I don't think it's possible. But I do think it's possible for us to change that. Now, you mentioned that data. What I found, and I've seen it, what I found heartbreaking about the data, the double-digit reduction in the number of a proportion of Black and Hispanic students in medical school, is that some of it was from people being admitted, but some of it was from applications. So they were just scared away from even applying, it seems, or whatever was the reason they're not applying. And so we've got a lot of supply chain work to do. So we've got to be visible. We've got to. It's not enough for us now to inspire that college student to want to go to medical school. We got to go back to high school. We've got to go back to earlier than high school. One of a very impactful study upon me was a study that was a cohort study of children. And it looked at children in the kindergarten. They asked them what we always like asking children: what do you want to be when you grow up? It turns out the data shows that the similar proportions of Black, Hispanic, and white kindergartners say they want to be a doctor when they grow up. But in this study, they followed them. And by the 8th grade, there was a significant reduction in 2 groups in particular, Black boys and Hispanic girls, who were still saying they want to be a doctor. So something from kindergarten to 8th grade makes minority children stop thinking that they want to be a doctor, or that maybe that being a doctor is realistic for them. So, long-winded answer to your question, one of the things that we have to do is we've got to continue the good work that you're doing now with the residents, but we've got to find ways to go upstream and work with children and get them inspired. So 10 years from now, we're going to see a robust increase in college applications and medical school applications, so on and so forth. But we also need our own leaders, people like you, working in medical school admissions and college admissions, community college admissions, et cetera.
Dean.
Thank you very much. I'm Barbara Bass. I'm the dean here, I guess, here at the George Washington School of Medicine and Health Sciences. So thank you so much.
No,
It was really a terrific
thank you. Nice to meet you.
presentation, and very nice to meet you as well. My question follows on to that of Dr. Onuma about the most recent data, and really some of the significant real hardships that have been added to our system to implement those values that we at this school certainly hold very near and dear, that no question a diverse healthcare workforce provides better healthcare. not just to our community here, but wherever they happen to be. And yet we do have these new boundaries around us that we're looking for, quote, surrogates, which I suspect soon will also be the subject of dismissal. So I would really love to hear your thoughts on that, and the new data, of course, that have just come out about this year's class. And our class reflects that data, absolutely. I mean, in a maybe even more augmented way than some others. It's really discouraging for us. Or I don't want to say discouraging, but it's really, it's like, whoa,
It's challenging.
the
Yes,
reality just
yes.
hit us. It really got
Mhm.
here real. So I would ask if you have other thoughts about what are some of the tools we might use for that. But secondly, I also, just in a more broad kind of question that maybe you've sort of already answered that first one a bit, would be just the wonder of resilience and fighting this battle. You know, if you look, I don't know how old you are. I know how old I am, and you didn't ask me if I was a student, but other than that, I think that really the just the constant perseverance and resilience and these, these waves of, oh, maybe we got it this time. And I'm a child of the 60s, so let me tell you, I've seen it all through this time.
Yes.
And I just wonder, how do we convey that passion and that drive and that mandatory faith, hope, uh, you know, we got to keep doing this to those that are coming along, that are going to be you and me in the future, because sometimes it feels daunting. Can you talk a little bit about that side? It's a more personal question, I think, but an important one, I think.
Yeah, yeah. One that I'm happy to address. Thank you for the thank you for both of those questions. So I'll start with what are some tools you can use. So I tried to show some of that in that grid that we use for our interventional cardiology fellowship. So you may not use race as a criterion for admission, or even look at ethnicity. But there's nothing that says you can't look at what people have done. What have they done? If you think about it, if you if you have a special grant to hire a future researcher, what you usually do is you say, well, what they've done in the past is a pretty good predictor of what they're going to do in the future. So of these applicants, I'm going to look at who's done the most research, because that'll give me the chance of selecting somebody that's going to want to continue to do research. If one of the missions of your medical school, and I hope it is service to underserved populations, then look for that in your applicants, to your residency, to your fellowship programs, to your medical school, to your faculty. And while there's no guarantee, if they've done it in the past, just like if they've done research in the past, then they're more likely to do that in the future. There is no law saying that you can't make one of your criteria upon which you have quantitative analysis, that you get points for these things. There's nothing wrong with saying that. Now, that means that not everybody who is doing healthcare and health equity work, and certainly not everybody is a person of color. There are many white people who do that work too, and I say bring them on. Let's have them in our medical schools as well. So that would be one thing I would encourage you to think about, looking at your selection criteria. And now that we can't look at race and ethnicity, what you can look at is, well, who is doing the service to the underserved that we want to see? And that's looking at people's track record. And there you will get some help. The second part of your question, these are trying times, but I remember being in elementary school, and I've always been a student of history, and reading about the challenges that my parents' generation, my grandparents' generation had to go through, like not being able to drink out of a white only water fountain, or going to, and thinking, oh man, we don't have any battles left to fight. I wish I would have been born 30 years earlier so I can go through that. Well, guess what? Now this is your turn. If you're a young person, you no longer have to say, I wonder what it was like to be in a time where we're forced to do something to change the world. You're living in it. You're living in it, and you're on the clock. So I think letting history be our guide is our best option.
We have a question back here from our Associate Director of our Upward Bound program.
Hi, my name is Gabrielle Mitchell. I work here. I don't have a background in medicine. I have a background in education. But hearing you all talk and seeing the graphs that I could read, it was very informative. I recently have been getting in contact. I mean, our program is really about connecting folks, right? We work for college access, so we're working to get young people into college.
So you're working on that supply chain already.
I'm working it.
Awesome.
I'm trying my
Awesome.
best on the
Yes.
supply chain. And so recently I got in contact with some former colleagues of mine in Philadelphia. I worked in Philly as a teacher, and I've seen what you say, right? I was working in a school where we're told, don't drink from the water fountain, it's got lead in it, right? But our kids drink, bathe, play, clean in that water, in those pipes. And the solution is, well, rebuild the area. Well, they don't get to live there anymore. That's their grandma's house. Now they're getting bought out. Now nice new people get to live there, right? So a colleague of mine has started a program called Future Doctors Teach, and he's really working hard and collecting wonderful medical students who really want to educate young folks, right? One thing he learned recently is that in the schools that I used to teach in, most of our students are not getting any science education until they get to high school. Yet they're being tested at the end of the year on content that they have no chance of knowing and learning, right, in these schools. And so he's working really hard on just getting them at least halfway prepared, right? Because then when they get to high school, they're way behind their peers. They don't know half the stuff they're supposed to know. And so he's reaching out, we're talking, I'm trying to get them connected to NIH because we have a connection to them. But my big question is really for programs such as those who are working on that supply chain and have people just volunteering their time, because these med students are not paid. And I know you med students, you people in science, time is money for you all. There's a lot of studying and learning, and you're always learning. And they're just giving their time to these students in these communities. How, other than connecting them, right, to the best of my ability, how can I help them grow? That's one of their biggest things, is growing. How can they learn about those conferences and get into those conferences? Who should they be reaching out to at universities and organizations to make new connections for themselves? Because the work that they're doing is really, really awesome. They have like Medical Mondays, and I'm trying my best, but I only know so much. And I mean, I'm gonna try to connect them to GW a little bit. But I mean, they have really great medical schools in Philly, but how should they be attacking it to get in front of the right people?
Well, I'm very pleased to hear about that program, and very pleased to hear about the work that you're doing. It is so very important. It really is the future. You mean you're working on the future. So keep up the good work and give my solidarity to those medical students. So you mentioned you do have several awesome medical schools in Philadelphia. So working with they have, as far as I know, their diversity deans haven't been outlawed yet. So they can work through the diversity offices in those medical schools or other allies in those medical schools. They can just reach out to the student affairs deans. Also connecting them with some of our civic organizations, medical organizations. The National Medical Association is kind of the premier organization of Black and other minority physicians. Philadelphia has a large chapter, so just NMA, the National Medical Association. And those should be some good places to start, with the medical schools and with the NMA.
All right, we have 3 more questions. We'll take Kennedy, then Dean Norris, then Dr. Carter Brooks.
Hi, Dr. Capers. I'm Kennedy. I'm a second-year medical student here at GW.
Do you remember that survey, your first week of medical school?
I don't. I was
You
trying.
know, yeah.
I don't think we probably took it though. But I received some advice earlier this week, and I wish I could say it was the first time I received that advice, but it reflects a pattern. And that was, as a student, though focusing on health equity research and work is important, it has the potential of limiting my marketability for residency because it doesn't really fit into a specific field. And that if I am interested in health equity research, I should maybe channel interest into like primary care, public health research, which is just reiterating the rhetoric of the Flexner report that came out decades ago. And you talked about causing good trouble and continuing to do the work. But what is your recommendation for students trying to do that while also trying to still get a place in the field altogether? And I know you mentioned the questionnaire on the residency application about saying the work that you do, but when you hear it over and over, you kind of question whether or not you should be doing that work or changing what your interests are. Thank you.
Yes. So thank you. Just awesome. And thank you for that question. So I couldn't disagree more strongly with whoever told you that working in health equity, diversity, disparities will limit your how attractive you are as a residency applicant. And just to help yourself and your classmates through that, just think about the places that you think you might want to do your residency. I would bet you almost any amount of money, if you go on their website and look at stuff that they have published, that they're publishing stuff on health equity. Everybody's doing it. So that would not make you a less attractive candidate at all. So continue to follow your passion. You've got wonderful faculty mentors, wonderful faculty colleagues. You got people here that I know have your back. Continue to chase your passion. Now to the second part of what you're saying, you know, as a medical student, as a resident, as a fellow, as a trainee at any level, you do have some vulnerability. So you have to be careful, make sure that you're always professional in your interactions with people with whom you disagree. I'm reminded of a time when one of our neurology residents at Ohio State, this is a Black woman, she was on the team as they were making rounds on the stroke unit, patients who'd had a stroke. And the physician, who was a white male, somehow got it in his mind it would be a humorous thing to do. He said, well, you know, Black people like hot sauce. So as I go in and meet these families, I want you all to keep track. I'm going to ask everybody what kind of hot sauce they like. So we would walk in and meet this stroke victim and their family. What kind of hot sauce do you like? And somebody would write down, oh, they like Red Devil hot sauce. And they go to the next room, what kind of hot sauce do you like? And so this Black woman who was the resident there, that really bothered her. And she wondered what she should do. Should she speak up? But as residents and students always have, I remember, because I used to be a student, you're always so paranoid that if I speak up, then I'm not going to get a good letter of recommendation, then I'm not going to get my fellowship, then my life is over, then I'm going to be, you know, we understand that, But just be professional in all of your dealings. When something like that happens to you, you want to like pull in your faculty. She did confront him after the second patient before the third. She said, I don't like this line of questioning. I don't understand it, and it makes me feel bad. And he stopped. So she could have got that across in a different way, in a more confrontational manner, but she got her point across, and it stopped. But I understand that even that you might be hesitant to do, because you might say, well, I'm going to need a good recommendation from this guy, so let me not do that. But we need you to at least report those kinds of things. So you do have some vulnerability as a trainee, but remember your allies first. So when you have a question about whether or not you should speak up or challenge something, go to one of your allies on the faculty first.
Dr. Capers, thank you for a marvelous talk. You did.
Welcome.
Yeah, it was a great job of illustrating so many things. I wanted to talk or ask you in regards to, we've talked about kind of recruitment and things of that nature. I believe our colleagues in undergrad would also say one of the challenges that we face is retention, particularly when we've had lower numbers of those historically underrepresented in medicine. Those of us who sat on different committees in regards to academic promotion know the profound effects of losing just one or two when you maybe start out with 3 or 4. I was wondering if you could comment on any data that you might know specifically on the effects of mentorship in retaining those historically underrepresented in medicine and helping them continue to push through that journey.
Oh, well, thank you for the question, and thanks for all the good work that you're doing here. There's no doubt, and the literature is replete with the positive impact of mentoring, particularly in minority background. So you see somebody that looks like you, that is doing what you want to do, and they're telling you, you can do this. That is incredibly powerful to the soul and to the spirit. So I think there's no doubt about that mentoring is important. What we have to take into account, though, is you all might have heard of the kind of the minority tax, or sometimes we call it the black tax, and that is if you only have 2 blacks on your faculty, and you go and get those 2 blacks every time you're interviewing a black faculty candidate, every time a medical student is having some problems, every time somebody wants a diversity lens on their grant, you're going to burn them out. That's a minority tax. So you can't let all of that mentoring fall on the shoulders of only the minority members of the faculty. But we've got to make sure that we know it's everybody's job. And the important thing is, we talk about the minority tax. I will often say that you can make any tax feel better with compensation. And so you need to And so people need to be compensated. So in that example I gave, you got 2 faculty members that you're asked to do all this stuff. Either pay them, and that may be a difficult conversation
Yeah.
about salary, but then another thing you can do is make sure that that is recognized when it's promotion and tenure time, when it's time for them to get promoted. Very often our P&T committees, they really see with a singular lens, how many papers do you have? 1, 2, 3, they count your papers. How many grants do you have? 1, 2, 3. Oh, you mean 2 Sundays a month you go to the church and talk about high blood pressure to save lives? Oh, that's nice. But how many papers do you have? 1, 2. So we have to train, and that takes a dean's perspective, the P&T committees, that this kind of work should be able to get you from assistant professor to associate professor, or associate to full professor. And then if you're not paying me in money, you're giving me some compensation. Then it doesn't feel like a minority tax as much. So.
All right, and this is our final. No. Okay, so wait, hold on. Oh, go ahead. You want to?
You want to give her the mic so that the people,
Sure.
so that the people at home can hear? I don't know if they're at home, but. Thank you.
I'll speak through the mic, but
We have people on Zoom, so.
what's that?
We have people on Zoom, so.
Oh, okay, sure. So, the one thing that I do want to actually, I think, give you more credit about, we do practice through science and data. I love the fact that, you had the curriculum here at GW. We just started in our GME lecture series, kind of this diversity lecture where we have 7 kind of mandatory for our GME, meaning all of our trainees, so our residents as well as our fellows as well. And we've finagled 2 out of those 7, lectures that will be specifically for DEIJ. And that's very similar to what you're doing. Our first one was what our Pink and Pearl campaign, which was really looking at breast and lung cancer and how we have disparities with that. And we're hoping to move on as well and have this as a series. So I thank you. The one thing that I will say, the reason why we started this was really because, everyone has a different level of training, as you were stating, coming from different medical schools. They may be privy to the information based upon the science, but everything comes in context as well, right? So, just saying that we have a DAIJ curriculum. I think it's important for all of our future leaders as physicians to understand what that science is, and that's what we're trying to do. So for you that, heard the diversity, and having any type of research, with related to that, I think that it is important to know that it is important work and you can move mountains with that data. And one of which is, I will say, what I have tried to do and what others have tried to do as being a part of the American College of Radiology and the Society of Breast Imaging, we got the guidelines changed for breast cancer screening. So it's a very important thing, knowing that Black women die, at a higher rate than white women do. So I think it's very important work, and I'm sorry that you had to hear that from somebody, but just so that you know. So it's more of a comment. That's all I had to say.
Awesome.
Thank you very much.
You. All right, and this is our final question.
Hi, how are you?
Hi, I'm fine,
Sherelle Carter Brooks. I'm a urogynecologist here and now the new OBGYN program residency director. So itching into that role. And I'm also the vice chair of the DEI committee for American Urogyn Society
awesome.
this year. I'm on the awards committee as well. So all of this was, I feel like this is one of the first lectures I've heard in a long time where I feel like I have hope, right? And so I'm not gonna talk too much because I know we're running short on time. My first question is from, I think it was the Cardiology Society that you started that mentorship program. Who's funding that? How did you get funding for that? Because that's something we're running into with OGS. And my second.
So let me take them one at a time. So,
Sure.
so private funding. So we're asking for donors, and these are mostly cardiologists in the community, but it's private funding.
Private funding.
So it's not American College of Cardiology money. It's private funding that comes in and is kind of unrestricted, and we use that money.
Okay, thank you. Second question that I kind of ask everybody who gives a talk like this, something that doesn't tend to come up is.
But can I?
Yeah,
I'm sorry, just one more thing, yeah, because I don't want to seem. However, that program that I pointed out to you, our meetings are on Zoom, the webinars are on Zoom, and we have them all come to ACC for a program. That, as you might imagine, that's the big cost, all those plane tickets. But even if we didn't do that anymore, the other stuff is free.
Well, it's somebody's time
Well, yes. Well, we do those on Saturdays. So,
donated.
yes, the time is donated. Yep. Anyway, I just wanted to make that clear because I didn't want you to think, oh man, we got to go out and find some private donors. You don't necessarily have to bring them to the meeting every year. So, but anyway, I'm sorry. I wanted to get that out before you got to your second
That's
question.
helpful. Being someone who's obviously a Black woman who's trained in medicine here, we talk about minority tax, but there's actually for Black and probably other URM trainees that it just seems like it's not talked about. Like I talk about it with my co-residents when we think back to residency and what training is like, and 10, 15 years later, we can all like laugh and joke about it, but it wasn't funny at the time. We all made it through, but it was just kind of like, you're going to deal with this thing, and probably everybody does, right? And like make it through, but how you're treated by staff, nurses, attendings, whatever. I mean, it can be pretty. And then also witnessing people who look like you having horrible outcomes. A lot of students that come into medical school probably come from reading applications, more stable home environments, right? Like you've had food, you've had shelter, mostly to get you to that point. And then you see all these things happening to people that look like you. It could be your aunt, it could be your grandmother. And like, how do you deal with that? And then I think dealing with that on top of just trying to like do all your admin tasks. Maybe you haven't seen someone navigate how to submit duty hours, pay rent, pay bill, whatever, do all these things to survive that you'd be able to do in residency. And so I think that it's something that is probably still happening. And I try to think about, okay, how do I address this for my own residents or my own trainees? But how can we give them the support, but also have the system recognize that they may be going through things more so than just the tax, right? But there may be actual trauma that's happening here from seeing what's happening, and how do we support them through that?
Yes, well, thank you and that's a very important question because you're talking about the environment, and it's a real shout out to the need for an inclusive atmosphere and an ecosystem that our trainees are in. Some of the answer to that is education. And not only, and when I say it now, I'm not talking about educating the trainees, they know what they're going through, but it's educating the faculty, the nurses, the staff, who may need to think about things differently, who may be unaware that I'm going to call everybody by their first name, or they may be unaware that behaving in a certain way might not be a one size fits all for everybody. So education, I think, can help, and that will be, again, not falling on just your shoulders, but you probably have business resource groups or staff organizations, everybody needs to have this kind of education. And it gets back to hiring people into your organization, right? If you're hiring people into the organization who have had experiences with people other than their own kind, then you are more likely to have a more inclusive environment once you do. So these are tough things that won't be fixed overnight, but having people like you and others in place is a darn good start.
I want to respect the time. I want to thank you, Dr. Capers, for not only bringing information to us, but encouraging us during these very difficult times to stay the course, to get into some good trouble. I want to thank all of the leadership of the School of Medicine and Health Sciences, particularly our dean, for being present at this presentation. That means a lot to us. And we know that the school is still, their mission continues to be that we will diversify the health force. No matter what kind of laws come about, we're going to find ways to get around that because we know it's going to lead to better care for all people. And what are we here for if we're not here for that? So I am encouraged, despite all the challenges, and especially despite what will happen on Monday, I am encouraged. We will not lose sight of our goal. So thanks to all of you who came in person and those of you who are online. Thanks to the staff of the Office of Diversity and Inclusion for continuing to push this talk in honor of Dr. King and, you know, keep hope alive.
Amen.
Thank you, everyone.
Well, thank you. Thanks, sis.